So thank you for giving answers to these questions, and we start with my first presentation, that is diagnostic challenges in MPN. And as mentioned before, this is mainly a case-based presentation that starts in a, I would say, unusual way. Mathematics has not been one of my preferred field of study. Anyway, what is the role, what is the significance of this presentation if we are in a very clean situation where A is different from B and B is different from C, so that A is supposedly different from C, and of course A is PV, B is ET, and C is PMF. So the answer is clearly no, because we know that these disorders are overlapping, that there is a continuum in terms of phenotypic presentation. And this is also the basis for thinking about the possibility that these different diseases that have, that have a similar mutational background may represent a continuum of a unique disorder, at least for PV and ET, but we have also to consider that there are specific categories that fit in part within one and the other group, such as, for example, prefibrotic myelofibrosis, and we have diseases and patients who progress to, for example, post-PV myelofibrosis or to acute leukemia, either through a myelofibrotic phase or directly from, for example, a polycythemia vera disorder. So there are two cases that will be presented. These are quite ordinary cases, nothing unusual. The first one in March 2008, a male colleague, 53-year, presented to the referring physician because he was suffering from cephalea and tinnitus in the last few months. Otherwise, he was perfectly well. He was working a lot. He had no previous event, and he had no concurrent cardiovascular risk factor. And at his blood cell count, it was found to have 23.3 grams per deciliter of hemoglobin with 68.9 hematocrit. White blood cells and platelets were within the normal levels, and also the differential leukocyte count was normal. He started the phlebotomy, of course, the same day. He was seen by an hematologist. There was no physical findings. There was no splenomegaly. The EPO levels were very, very low, and he was found to be JAK2V617F mutated with an allelic burden of 46%. He was BCR-ABL negative, and there was no abnormality in his karyotype. He performed bone marrow biopsy, and this was consistent with the criteria of the WHO criteria, of the WHO description. And so this patient clearly falls very well within the WHO 2008 criteria for polycythemia vera. That includes major and minor criteria. The major criteria are an hemoglobin greater than 18.5 and 16.5 in male and female respectively, or any other evidence of increased red cell volume, the presence of the JAK2V617F or JAK2 exon 12, or even more rare and less well understood mutations that may be associated with erythrocytosis. The minor criteria include a low erythropoietin level below the normal reference range, the presence of endogenous erythroid colonies that are a hallmark of this disease but are quite difficult to be performed in routine labs, and finally a bone marrow biopsy that shows hypercellularity matched for the age, with panmyelosis involvement of all the three myeloid lineages with prominent erythroid, granulocytic, and megakaryocytic proliferation. And for the diagnosis, you need the two major criteria and one minor criteria, or the first one of the major criteria and two minor criteria. And of course, our patient had enough of all these criteria to be diagnosed as polycythemia vera. So this is what we already said. The treatment had already been started with phlebotomies. He was low risk. He was 53. He was not smoking, no additional cardiovascular risk factor, and he was maintained on phlebotomies and low-dose aspirin. Clinical case 2 This is a 67-year-old male who retired from his work. There was nothing of relevance in the medical history apart from mild hypertension that was well controlled by his drugs. And during routine examination, he found 17.3 grams per deciliter of hemoglobin. White blood cells were normal. There was a slight predominance of neutrophils, but there was an increase of platelets that were 560,000. Mild splenomegaly was found at the physical examination 4 centimeters from the left costal margin. There was no symptoms, but he was asked, and he said yes, about pruritus, especially after shower. The abdomen scan confirmed a mild splenomegaly. The EPOL was low. The JAK2 mutation was positive, and the bone marrow biopsy was consistent with polycythemia vera. However, in this case, we could not make diagnosis according to the WHO criteria because his baseline level of hemoglobin was not 18.5, but it was 17.3. We made a diagnosis of polycythemia vera based on the criteria that we had at that time, and this is the basis for discussion. And since he had no thrombosis, but he was more than 60 years, he was considered at high risk. And we started treatment with hydroxyurea, phlebotomies, and low-dose aspirin. What is of interest in this case? The fact that we made diagnosis of polycythemia vera, yet these patients did not fulfill all the basic criteria for PV according to the WHO, and particularly the level of hemoglobin. Of course, we could have other ways, other means to demonstrate that the red blood cell mass was increased in this subject. Of course, we could have made a red blood cell mass measurement, but this is performed very rarely in our center, and I suppose in most of the centers, and this might be also a point for discussion after all. But now we are quite safe with this diagnosis that was made 3 years ago, after there have been an accumulation of data that suggests that there is a category of patients that would not fulfill the WHO 2008 criteria, yet they might be considered to have polycythemia vera that may be called as early polycythemia vera, masked polycythemia vera. We can add some kind of wonderful attribute to the diagnosis, but polycythemia vera is still that way. And the work performed mainly by Tiziano Barbu in collaboration with several others of us has clearly defined the occurrence of these new cases. And at the end of the story, we have to think about the possibility of having polycythemia vera when we have an hemoglobin that is at least and greater than 16.5 grams per deciliter in a male and 16 grams per deciliter in a female. And of course, there is the JAK2 V617F mutation, and there is a bone marrow biopsy that is consistent with the definition of polycythemia vera. And this is important because this concept has been discussed at the last WHO meeting that has been held, I think, about 1 month ago, and this is a proposal for revising the criteria for making diagnosis of polycythemia vera in the upcoming WHO scoring classification system. Polycythemia vera is therefore a disease that both our patients had. One had an over polycythemia vera, 23 grams. The other had a so-called masked, or as you like to call it, polycythemia vera. But in any case, the diagnosis could be made possible because of the presence of the JAK2 mutation and the bone marrow biopsy. So what can we expect in the clinical course of this patient? They can remain very well controlled by treatment. They have an increased risk of thrombosis. This is all well known. They may have an increased risk of hemorrhages too that are not so clear, that are not associated with the use of aspirin that remains a basis treatment for all patients with polycythemia vera according to the results of the ECLAP study. But of course, we can also expect progression of the disorder along with time, and the disorder may evolve into a post-polycythemia vera disease or transformed to acute leukemia. So what happened in the follow-up of these patients? So in case 1, all went right till July 2012, when the patient reported progressive worsening of the general status with asthenia, night sweats that were absent at the diagnosis were present. There was mild splenomegaly, not so significant, 4 centimeters, but he had stopped making phlebotomies since 9 months, and there was also an increase in the level of LDH. 6 months later, he was tendentially anemic. There was no clear iron deficiency in this subject. There was an increase in leukocytes. There were a few, but they were present, immature myeloid and a few erythroblasts in the blood film. The patients were slightly increasing, and again, this was not related to an iron deficiency. There was a further increase of the spleen, and the patient was heavily symptomatic, and in particular, he had lost some kilograms of body weight. The other patient was on hydroxyurea that was well tolerated, and his values were well controlled. He was not symptomatic. There was a mild reduction in the spleen volume. And so coming back to the case number 1, in general, we decided to see if something was happening in this patient, and we repeated the bone marrow biopsy that showed a grade 2-3 fibrosis according to the European scale. Fibrosis was 0 at the beginning. At that time, there was an abnormal megakaryocyte proliferation. There had been an increase in the allelic burden that was 46% at the beginning in 2008, and now 5 years later, it was 89%. And there was also a modest increase of the number of circulating CD34 positive cells in the peripheral blood. So this is clearly 2 different ways of proceeding of the disorder. In the first case, we went to the diagnosis of post-polycythemia vera myelofibrosis. The second patient was doing well as still a true polycythemia vera. The diagnosis of post-polycythemia vera myelofibrosis relies on the criteria that have been drawn by the group of the International Working Group from MPNs, and they include necessary and additional criteria. The necessary criteria are, of course, a prior diagnosis of polycythemia vera according to the WHO 2008 criteria that should include also bone marrow biopsy, and the development of a grade 2-3 bone marrow biopsy on the European or 3-4 on the American scale. These are required, and then you need 2 additional criteria that are anemia or a reduction of cytoreductive or phlebotomy requirements, the appearance of leukoerythroblastic picture of the blood, an increase in the spleen volume, and the development of at least one of the 3 constitutional symptoms. So again, these patients fulfill the criteria for the diagnosis of post-polycythemia vera myelofibrosis. So how should we deal with this patient? If we consider this as a myelofibrosis, this patient has, among the different variables for the score, this patient has only constitutional symptom. So he would be diagnosed as an intermediate 1 in terms of prognostic risk with an expected median survival of 95 months. And how then we behave with these patients. Of course, he didn't have less than 10 grams of anemia. That is the level that is required for the scoring systems in myelofibrosis, but he had 10.9 and he was symptomatic, he was asthenic. There was splenomegaly that was symptomatic, and there were constitutional symptoms. So we proposed at that time to the patient to enter a clinical trial with the JAK2 inhibitor. He refused, and so we started prednisone, hydroxyurea, EPO when the hemoglobin went down 10 grams of deciliter, and then danazol. And 1 year later, he was anemic, and he had failed a number of approaches. His leukocyte count was controlled by hydroxyurea. In the absence of hydroxyurea, he was around 35,000 leukocytes. The spleen had increased, notwithstanding the use of hydroxyurea, and he continued to be symptomatic in terms of night sweats. There was a slight increase of blast. At this point, if we would use the same criteria as for primary myelofibrosis and use the dynamic score, at this time point, this patient would be in intermediate 2 with an expected projected survival of 48 months. But all what I have said is not completely true, because I have used for these patients the scores that have been validated for patients with primary myelofibrosis. So this is a common behavior in all of our practice. This has been used also for enrolling patients in clinical trials with the JAK2 inhibitors, but we have to have well clear in our mind that the risk scores have been developed and validated only for primary myelofibrosis patients. I can anticipate that there is a huge work that is being performed within the international working group that will focus specifically on post-PV and post-ET myelofibrosis. And I anticipate that Francesco Passamonti, who is working on this, should probably have the data within this year, and so he will pardon me for making these errors in handling the patient. And of course, we studied these patients because of our interest also on the molecular profile, and we found that these had a mutation in ASXL1 and had a mutation also in SRSF2. And so according to the concept that I have just presented before, and I will go very quickly, these patients belong to the molecular high-risk condition. He has more than 2 mutations, 2 or more than 2 mutations, and so this is an additional negative prognostic risk factor for this patient. I skip this one, but again, we have to have clear in mind that the molecular risk score has been performed and validated only in patients with primary myelofibrosis, and so we should be very careful in using the same information for patients who come from polycythemia vera and maybe from essential thrombocythemia to post-PV, post-ET myelofibrosis. And again, I can anticipate that we are working on this issue, and hopefully we might have some answer about with these questions later on. So just to know how things are going with this patient, the patient is now receiving ruxolitinib, and he improved the spleen. He had a rapid complete disappearance of the symptoms. He had some issues with the platelet count, but he had no need of red blood cell transfusion. And of course, we started making a plan for hematopoietic stem cell transplant for this patient. And this search is still ongoing. So at the end of this presentation, I have to admit that all what seems to be quite clear for patients with primary myelofibrosis is not the same for patients who transform to myelofibrosis from previous disorders, and we have to take this into account when we manage our patients. Thank you. And so